Yes, sir. Please start. Please start, sir.
Good morning, one and all. First, I would like to extend my thanks to Dr. Arunachalam, who is the speaker for the day, that he has accepted our request for speaking over this very kind of vibrant topic. So I would welcome, I think sir has joined, so I would welcome Dr. Arunachalam, sir. He is the chief of Sai Ram healthcare facility at Chennai, and he is running Sai Ram educational part also. Sir is PhD Gait, and he's a very senior professor and PhD Gait at Madhav University, Rajasthan. He has a long credential list. He has been into many editorial team. He has been in part of many publishing papers. So like I would welcome, sir, kindly come over the screen, switch on your video. So I would welcome on behalf of my whole team of My Rehab Academy. His long credentials, he has done many events with us, and he is a scientific coordinator also for My Rehab Academy. So I would welcome sir for today's topic.
Yes, sir. Thank you so much.
Thank you. Yes, sir.
Yes,
Before you start, I think you'll be taking PowerPoint presentation, so you can start.
I'll share. Yeah.
Before that, I would inform the candidate that our own events like dry needling by by Sir Craig Smith. It's getting feeling faster in Bombay, August 2nd to 6th. So 5 days event, both the module, and people are loving that. So please book your seats, and then we are giving kind of facility of discount as well as very easy payment method for our students, for our members. Apart from that, other events like electrotherapy and everything, many calls, even the X-ray from me, again, there is a call, and other events like put evaluation, that event is also on the board. So very soon you all can attend that. Everyone is getting information through their mail and through their WhatsApp group. So whoever wants to join can always welcome you all to contact our my number or Academy's direct number. Just send the message. We will let you know the best. Sir, all yours. I'll be coming again after some time. Please carry on, sir.
Yeah. Thank you so much, Sarojji. Welcome to all the participants for today's presentation. I'm so happy. I always extend my thanks to the 4 pillars of My Rehab Academy. Sumanji, Dr. Saurabh, Dr. Divakar, Dr. Kalimullah. I really wonder their persistency and consistent efforts they throw towards students and the educating part of physiotherapy. And many academies have evolved in the COVID time globally, but very few have sustained and been successful in that. And My Rehab Academy is one such academy which has blossomed and has gained momentum and has achieved a lot of credentials now. Attending one My Rehab Academy program or being a tutor for one academy, this My Rehab Academy program has become so wanted nowadays. Many teachers wanted to teach in My Rehab Academy, and they have gone from strength to strength, and I am so thankful for that. And at the outset, I would like to apologize for canceling the program last week because of my personal reasons. I never do that, but this time it has happened. I'm very sorry for that. And with that, we will get into this today's program of gait rehabilitation among stroke patients. So I have been educating on my own school of approach called as functional biological approach. Of course, this is from the contributions of many motor behaviors, motor theories, behavioral theories, and learning theories. I have taken elements out of all these theories, and I have framed my own protocol called as functional biological approach. So FBA do also have my own inputs. Some sandwiching has happened in this approach, but none of them are pseudoscience. That is, all of them are science-based approach towards stroke rehabilitation. So why I have started propagating this functional biological approach is that we are still stuck in the ideologies of 1980s and 1990s, which have been eradicated in the Western countries, but still we follow that because of our poor education system. So without wasting much time on these current scenario, I would like to take you a walk through the principles of functional biological approach. Okay, based on these principles only, we are going to rehabilitate stroke patients for Gait in this particular session. So first is human as a biological unit. When I say functional biological approach, this biological name you would have not seen anywhere, but this word has been coined in this particular approach is because human beings are highly evolutionary. They tend to get adapted to situations very faster. Small example for that is 3 days before I lost my mobile, my smartphone. I lost my smartphone, and I am using this small little Nokia phone, which is very useful for me, giving me a lot of peace. Initially, first day, I felt so bad because I cannot do money transaction. I am not able to reach out to people with WhatsApp, and all these problems were there. But slowly, second day, third day, and today is the fourth day, um, I'm feeling much comfortable with this, and I'm carrying a wallet full of money. I'm talking to many people without looking into my mobile, and I feel the change. I'm so happy. That is what is called as evolutionary. We keep evolving, we keep changing, we keep adapting to any situation in which we are put into. So this is very, very important aspect of a stroke patient. In stroke also, in that case, any neurological conditions, particularly stroke, if a person is put into a position where his one half of the body is not working, he tries to come out with some or the other way, any alternate source to adapt to his daily needs. So that is when the patient starts doing unwanted movements. Who he starts doing not an unwanted movement, an abnormal movement which is not which is highly energy consuming, which is very stereotypic. That is one similar type of movement for all his functional needs. And his ultimate goal is to adapt to the new ambience. So we have to look stroke patient from that point of view. Okay, so adaptation can take place negatively and adaptation can take place positively. So what is the role of a physiotherapist? This positive adaptation, positive remodeling, what we are planning to bring about in the stroke patient, that is the role of a physiotherapist. Nothing more than that a physiotherapist is going to do. He cannot simply give medication, or he cannot give you any injections or anything like that. He can alter the biological unit. This is the first principle you have to understand. Second principle is purposeful and functional movement re-education is what you have to do. For example, a patient who is 83-year-old, he's having stroke. He comes to your clinic. You make him sit in on a Swiss ball. On a Swiss ball, he might have not sat in his entire life, but you make him sit on a Swiss ball. He's already having one half of the body impaired. What purposeful movement you are planning to bring about from this particular action? Instead, if you are making the patient to stand, instead you make the patient to walk backwards, you make the patient walk sideways. All these things are purposeful. Everyday life, we have a purpose in doing these movements. So whatever movement you are doing for the stroke patient, it should be purposeful. Okay, and functional movements is daily functional activities of daily living. When you ask a patient, how are you doing now? What the patient says, sir, now I am able to go to toilet on my own. Now I am taking the blanket and covering myself without anybody's help. Sir, I am able to transfer from my car without any support. So these are the answers patients give. So when the patient won't say that my spasticity has gone down, my range of motion has increased. All these things patients will not say. Patients will say in terms of functional activities. So your treatment should also be based on functional movements and purposeful movements. Any movements you do, that should reflect in his day-to-day activity. Second thing is patient-centered treatment. There are three types of treatments available. One is intervention-based treatment. For example, if you go for a Mulligan concept or a Maitland concept, they approach every condition from their theoretical assumption point of view. Am I right or not? If you go to NDT, their concept is their intervention. They have devised some protocol, and that protocol is what they are going to apply on the patient. Irrespective of what the patient wants or irrespective of the experience of the physiotherapist with the other approaches, they don't mind it. They approach it from their point of view. So they have a theoretical belief and they apply that on the patients. This is called as intervention-based approach. Second thing is therapist-based approach. Therapist-based approach in the sense the therapist might be an experienced guy. He might have a vast experience in treating stroke patients, and he will have some assumptions. See, we have to make the patient sit first, then stand first. After that, only we have to educate the hand function. And like that, he might have had some success with previous patients. And the same thing he will apply on the every patient. So this is called as therapist-based treatment system. The third very important and what I prefer is the patient-centered treatment. You ask the patient one very important question like, what do you expect from this physiotherapy session? What do you want down the lane after 1 month from this physiotherapy session? What are the progressions you want to have? Patients will definitely say, sir, I want to stand, sir. I'm not able to stand. I'm bedridden. It is very agonizing to be in bed. I want to move out. I want to go to the toilet. I want to take care of my own functional needs. So he will prioritize certain things. If the patient says, I want this thing first, then that is what you have to concentrate on the intervention aspect also. Very important example. One stroke patient who was living in a ground floor, who has not climbed the stairs all the previous 10 years because of osteoarthritis of knee. He comes to a physiotherapist for stroke rehabilitation. So the therapist makes him walk very nicely. He makes him sit and all these things. And he starts him onto staircase climbing, which the patient has not done for the past 10 years because of pain. The patient will definitely have an apprehension towards the staircase climbing. He doesn't want that. In his functional activity, he has lived for the past 10 years without staircase climbing. And what is the purpose of making him to climb the stairs? And the patient will develop aversion towards physiotherapy. So we don't want that. So what are all the functional needs of the patient? If they are fulfilled, then your treatment is going to be successful. This is the third principle of FBA. The fourth principle is opportunity for adaptation to take place. If a therapist goes, he treats a patient for half an hour or 45 minutes in a day, and the patient lies down simply without any other activity, nobody is there to guide him. The very next day, the therapist goes, he goes and give a treatment for half an hour to 45 minutes. Nothing is going to change because the patient practices normal behavior for 45 minutes and abnormal behavior for is going to practice the abnormal behavior for the remaining 23 hours, then what realistic change you can expect from the patient? So what you have to give is opportunity for the adaptation, positive adaptation to take place. And you have to keep the patient practicing. More he practices, more the adaptation takes place. And in this aspect, you have to keep in mind the capability of the patient. If the patient is a chronic COPD, or the patient who has gone for a cardiac surgery, or the patient is a debilitated patient for a long period of time, patient having a HbA1c of more than 10, 15, or the patient is having some other comorbidity that is limiting his functional activities, or prolonged bedridden patients. For these patients, you should know what is the optimal range of exercise and what is the optimal practice sessions you have to give, because you should know how much is too much for every patient. Remember this. Okay, so apart from that, on a general lines, if you talk, opportunity for adaptation is a very, very important aspect. Fifth is unlearn unwanted behaviors. As a physiotherapist, you may not see the patient, every patient from day one of their stroke or immediately after discharging from the stroke. Probably you will go to the patient after 1 month or 2 months or even 6 months and 1 year. And you have to know what are the abnormal behavior patterns they are doing. the so-called the synergistic pattern is one type of abnormal behavior, but that is not the only abnormal behavior the patient has got. He may have a lot of abnormal behavior which he has learned over this period of time. So that you have to take care, and you have to make him unlearn that. That is a very toughest part of stroke rehabilitation, because you see, 5 days or 10 days uh, of learning will take nearly 20 days to 30 days to unlearn. That is the neuroscience statement. So when somebody has learned something for a month together, to erase that, it takes a lot of time, and a lot of positive reinforcement is needed for this. What is meant by positive reinforcement is the reinforcement you give to unlearn that particular activity is called as positive reinforcement. So unlearning unwanted behavior is very, very important, and then only you can come up with a realistic behavior. And last but not least, motivation and social restoration, which we most of the time fail to do. We start scolding the patient, we join hands with family people, and we criticize him that he's not doing any activity. But remember again, he is a biological unit. He will also have wills, and he will also have aversion. He will also have mood fluctuations. All those things you have to take into consideration, and you should restore him as a social animal where he was before, when he had stroke, coma, pre-morbidly, where what position he was occupying in the society. If you are able to replace, restore him at least near normal to that, then that is a real contribution you are doing. How often physiotherapists take a patient on road? How often physiotherapists take a patient for a shopping or all other social needs? For example, even a temple. How often we have taken them for a temple? Our treatment gets confined only to the room, to the hospital, to the clinic, and we never move out of it. We ask somebody else to take him out, but we don't do that. But in fact, it is the role of the physiotherapist for social restoration. It's very, very important. So these are the 6 major approach of principles of functional biological approach, which I have been educating. And I really have to elaborate on these things too much, which is not in the scope of this particular program. But when I teach gait management, these principles are being abided. So I really wanted to touch on these things on the first. Now, do you have any doubts on this? If you have, I'm ready to answer that before moving on to the core subject of gait. Any doubts? You can even type in the chat box. First of all, am I audible? Somebody has messaged. Yeah, I'm audible. Fine, great. So now we are moving on to the gait aspect. See, you should always be familiar with this gait cycle. I think many new therapists are there, as Saurabh requested me to be very basic because new budding therapists, students are priority for my rehab academy. So you all know about the gait cycle. So you can just see the left limb of the patient, which is in different color compared to the entire body. The initial, you can divide this entire gait cycle into double limb support and single limb support phase. Okay, so if you ask me one question, sir, whether the double limb support is affected for the patient or single limb support is affected for the stroke patients, my answer is both the phases of the gait is affected for the patient. Very important thing, what you can see is the double limb support is increased. The duration of double limb support, which is very minimal, you can see here, which is very minimal. 1:3 is the ratio actually. 3 stands for single limb support, and 1 stands for the double limb support. So, but in stroke patient, the phase for which they stand with both legs in contact with the ground increases compared to a normal person. So many people ask me how to do a gait analysis, not only for stroke, but generally. The first step for you to analyze gait is analyze normal people. There are a lot of variables in people's walking style. Many people walk in a different style, but there is a common underlying factor in in almost all the normal people. There may be a 5 degree or 2 degree, 3 degree change here and there, but on an average, everybody walks in similar manner. Even if you have not noted a normal gait, a person with normal gait from the sagittal angle and the frontal angle, you cannot directly go and visualize a abnormal gait pattern, because you should know which is normal. So I always say people, whenever you're waiting for an airport, waiting for a train or a bus or somewhere the other, if you're waiting in a seated position, always observe people's gait. You observe people's gait, you observe one leg first. In one leg, you observe the hip first, then the knee first, knee, and then the ankle. Then go to the other side. And then look into the entire body, the reciprocal arm swinging, how the body twists onto either side, how their head looks, where they look. All these things, if you observe a normal person, then only you can find out what is the difference in an abnormal person. Okay, now the initial, if you can start with this, is the right heel. If you see heel contact, the first one strikes the heel, the other one is about to take away from the ground. So we can say, we can start with this face, heel off, now toe off, now here the initial swing, the mid swing, the heel strike, the foot flat, and then the loading response, then heel off and toe off. These are the phases of the gait, what we are seeing in this picture. Now, without wasting much time, what are the common impairments in stroke patients? These are the common impairments, what I'm going to tell you. Mind you, there can be something beyond this also in other stroke patients, because one stroke patient will not behave like the other stroke patient. Based upon the extent of the lesion, based upon the location of the lesion, based upon the depth of the lesion, based upon the behavior, based upon the environment they are put into, based upon their pre-morbid habits, they will definitely differ. Okay, but I have listed out here some of the commonest impairments which 80% of the stroke patients will have. The first two things are reduced self-selected speed and maximum speed. You have two speeds of walking. When you're walking on a normal basis, you have, that is called as the self-selected speed. This is the speed at which I used to walk. This may differ from individual to individual. Normally, I prefer walking little faster because I'm a Rajinikanth fan. So I walk little faster. Right from my childhood, I mimic my superstar and I just walk little faster. So that is my self-selected speed. There are some people who walk very slowly. They have all the time in the world. They don't rush most of the time. So that is called as their self-selected speed. What is the maximum speed at which I can walk? That again, that differs from individual to individual. So there are two speeds which we have to emphasize on. So both of these two speeds are diminished in stroke patients. Normally, their walking speed is less. If you ask him to walk very fast, they cannot accelerate much also. So this is the first thing what you have to attest in stroke patient. Second thing is the magnitude of flexion, extension, joint angle in both the lower limb. Let it be the knee joint or the hip joint. If you see from the sagittal angle, you can see that, if you see from the sagittal plane, you can see that their hip excursion in flexion and extension is tremendously diminished on the affected side. And their knee flexion and extension is also affected compared to the normal side. So this is a very important spot of bother, because the affected side can also influence the unaffected side. If the affected side hip do not go for a good amount of flexion, the normal side hip will not go for a proper extension. Am I right or not? If the hip of the normal side doesn't go for a sufficient extension, the calf muscles cannot push the normal side for a swing with normal velocity. So because of the affected limb, the unaffected limb is also suffering. So what is the major problem here is the lack of range of motion, active range of motion. of the flexion and extension in both hip and knee. And you can say also dorsiflexion and plantar flexion. The third important thing is reduced hip extension at the end of the stance. All these things we will see with the picture also. So reduced hip extension of the affected side. The hip doesn't goes for extension, proper extension at the end of the stance, where end of the stance means the toe off. When there is no hip extension in the toe off, the momentum with which it is going to swing forwards is also going to be affected. Imagine you are having a pendulum, you take the pendulum to an extreme range and then just leave it, it goes for a big oscillation. Whereas you take the pendulum to a small distance and then leave it, it is going to oscillate only this much. So the momentum of the leg is determined by how far the hip extension takes place. If only the hip extension is sufficiently large, then the hip is going to, the leg is going to swing for a beautiful flexion. Okay. So re-educating the hip flexors is important. At the same time, re-educating the range of motion of hip extension is very important, particularly at the end of the stance phase. When the limb is preparing for a swing phase, you have to make sure that hip is in complete extension. But here it is diminished. That is the third problem. The fourth important problem is double support phase associated with a sense of poor balance. The patient always have an apprehension or a fear of fall, which makes him to stand with both legs. Particularly the time for which the normal leg goes for swing is affected because the patient has to bear weight on the affected leg. Am I right or not? The therapist, how much ever the therapist emphasize on loading the affected limb, the patient will not be so confident in loading the affected limb. He will definitely reduce the time for which the body is supported on the affected side. So the time he has got to swing his normal leg is very, very minimal. So he will not swing it properly. And we may think that the unaffected limb is also weak, but in fact, that is not the problem. The problem is the patient is not willing to transfer his weight onto the affected joint. Okay, that is the fourth important problem. Now, fifth is the vertical ground reaction force at the push-off, implicating weak or weakness of the plantar plexus. So what is ground reaction force? The pressure with which the feet leaves the ground is called as the pressure applied by the feet onto the ground, and the counter force that is applied from the ground onto the feet is called as the force couple that is useful in walking. So when the patient is having, imagine this is the heel and this is the toe. If the patient has this type of movement, then only he will do like this. He can go like, if the feet is completely flat, how he can push off? He'll just lift the leg and keep it like this. So when the feet are flat on the ground and there is no heel off and toe off taking place, when the patient is walking with complete flat foot, the momentum, that is the ground reaction force, is very minimal. And this itself can give instability for the patient. The patient may feel like he's not gripping the feet, the floor properly. And this will also affect the push-off phase of the affected limb. Added to this, the plantar flexors are also weak. For example, I'll give you one very important example. Many people who come to my clinic with osteoarthritis of knee, they cannot do skipping. Chronic osteoarthritis knee. Why they are not able to do skipping is simply because they have not practiced this high velocity burst of the calf muscle. When you want to skip, your calf muscle has to work, the power of the calf muscle, which acts within a matter of seconds to push your body up and down, that is lost in the patient. Those muscles which do this this quality, this movement is lost. The amount of acetylcholine that has to be gushed out of the neurotransmitters, neuromuscular junction is diminished all these days. There is no quantum of the acetylcholine quantum to do this. So as a result of that, what they do, they have lost is they are not able to hop. They are not able to vertically jump. This is because the calf muscle, though it is strong, it is not able to exert a powerful movement within a given time. So the same thing happens with stroke patients also because of prolonged immobility, walking with self-paced speed, walking with flat feet. They lose this ability to burst the calf muscle contraction. Okay, so that is the fifth problem. Next, sixth problem is reduced power generation, as I have already told you, from the calf muscle, from the ankle to push off. And apart from this power generation in the ankle, the hip muscle also loses its power to pull the leg forwards. So you have to understand there are two things that propels a leg from extension to flexion, body propulsion. One is the calf muscle pushes the feet forwards from a toe off position. And the second thing is from the toe off to the mid swing and the terminal swing, the hip flexors have to work very fast. It has to exert a good amount of force to propel the body forwards. So this is also lacking. So what are the important things we have seen? What are the muscles we have seen? So far, we have seen about the hip extensors, and then we have seen about the calf muscle burst, and then we are seeing about the hip flexors. Seventh is the reduced endurance. If at all the patient walks only for 10 feet, 10 steps or 20 steps or 30 steps, and they doesn't fulfill their daily functional need. And by the time they complete this 20 feet of walking, they will start breathing heavily, they'll sweat, they will have all sort of apprehension. And you can always see a stroke patient walking away from the bed, they walk very slowly. When they're walking towards the bed, they walk very faster. And the last two steps towards bed, they tend to lean forward and reach out desperately to the bed to sit down and lie down. If you have treated stroke patients, you will know that. This is because of the desperation for them to end this task. They are feeling that they are very exhausted. Like how after a good amount of play, you come and rest on the bed. As a normal person, you also get exhausted, right? So stroke patients can easily get exhausted. So that is a very important thing. Most of the time, we don't attest to the cardiorespiratory endurance of the stroke patients. It is very, very rare. How often we give high intensity interval training for a stroke patient? We don't give. But in abroad, it has become a habit for them because HIIT, that is high intensity interval training, has proved to be very effective in bringing about cardiorespiratory adaptation and increasing the cardiorespiratory endurance compared to any other exercises. But giving that for a special population is a big challenge. Unless otherwise we have the sufficient gadgets, we can't do that. But just I'm telling you, we don't concentrate mostly on the cardiorespiratory endurance part of the stroke patient, but that is very, very essential. The eighth aspect is reduced adaptability to changing environmental condition. You make the patient walk in a closed ambience with a restrained ambience. That is, nobody is going to walk in between. The therapist is there to supervise the patient. The patient is very familiar with the nook and corner of the room. What are the objects in the room? What is the texture of the floor? Whether the floor ramps up or ramps down. All these things he is very familiar with. Most of the time, we will always have a flat ground in which the patient will be walking. But if you see, when the patient goes to the to an open environment, he finds it very, very difficult to walk. He finds it very, very difficult to manage people who are crossing them. He finds it very, very difficult to grab onto objects if he's in a need for anything. So what he does is he reduces his gait velocity when he go to the community, and he tries to take support from others, whether it is his caretakers or the objects which is there in the environment. He fumbles literally, and he becomes very exhausted very soon. Already the endurance is less. Now he goes to the open ambience and his endurance is going to fall even more. Okay, so these are the challenges what the patients are facing in stroke with gait. Now, we will go with a diagrammatic explanation of these things, whatever I told you, these 8 aspects. You can see this patient. What is the problem with this patient? Can anyone say? I'll just rewind once again all these steps so that when you're seeing the pictures, you can see what is the problem with the patient. First is the self-selected speed and the maximum speed is diminished. Second one is the magnitude of the flexion and extension in hip, ankle, and the knee are all diminished. The third is reduced hip extension, in particular at the end of the stance. so that the pendulum swings very less. The fourth is the phase of the double support is increased in the patient, and the patient always has a sense of imbalance, and he always has a fear of fall. Okay, and the fifth one is the vertical ground reaction force, that is the calf muscle generating power is diminished. And apart from the calf muscle, also the hip flexor's ability to drag the leg forwards with a forceful movement is also diminished. Seventh is the endurance, and eighth is the social adaptability, that is going into the open ambience, uh, like a social walk. It's going to be very difficult in terms of the surface in which he's walking, the obstacles in between, unfamiliarity of the patient to the ambience. All these things are going to. So just think all these things and answer me this question. On your right side is a normal lady who's walking, and on your left side is a old man with stroke where he's walking and he's being assisted by a therapist. So can you find what is the difference in this patient? What is the problem of this patient? What is this? What is this patient is doing? You can see I've received one message. Let me see what is that. Lacking in hip flexion. Okay, that's good. Lakshmi has answered this. Lacking in hip flexion. Okay. Now, you can see when I draw a plumb line, you can see the hip extension of the normal side. The hip extension by the time the leg goes for a mid swing, you can also observe this. His thigh has passed the normal leg. Okay, but the hip extension is lacking. He's standing almost vertical. But see this normal person, his hip is in extension by the time the leg goes for a, the opposite leg goes for a mid swing. The hip is in extension already, but here it is not in extension. So what happens as a result of this? What happens as a result of this? If the hip extension momentum is lost, then the swing phase will also be affected on the other side. Okay, so the time at which the heel goes for a strike, you see this normal person, the knee has gone for extension already, and it is going to heel strike. But here the knee, the opposite leg is still behind the stance leg. So what happens? The momentum is lost. The hip extension of the opposite side leg determines the momentum of the normal, the swing side. So if the right hand is in stance phase, the hip extension that is taking place in the right side will affect the swing of the left side. So you have to re-educate that. So that is a problem in this patient. Okay. Now, also see, he is not doing a dorsiflexion. His ankle is either in neutral, or even I will say it is in plantar flexion only. Look at his feet. But whereas you see this person, she has taken dorsiflexion now. So the hip flexion, the hip extension and dorsiflexion of the feet will be acting as a major tool for the propulsion, major tool for momentum. Because his hip is not in extension, his the feet is not also in dorsiflexion. It is in plantar flexion, which is a mechanically disadvantaged position for a person to propel forwards. Got it? So these are the two changes what you can see. Apart from that, I would also say that his knee is in hyperextension. Whereas you see this patient, the knee is locked in a neutral position. Here he is having a hyperextension. So just imagine lack of hip extension, lack of dorsiflexion, and increased extension moment in the knee joint because of the fear of fall. He is going for a hyperextension. So these are the problems of this particular patient. Okay, now this patient, you can see very clearly that her left feet, that is the affected feet, you can see clearly that it is not pushing off as beautifully as this lady does. Right? You can see the feet. Here there is a clear toe off, heel off, and she's preparing for a toe off. And you see how far this leg is behind the stance leg, the distance between the stance leg and the push off leg. So this is a very important thing. I told you an example with the oscillation of the pendulum. The far it goes behind, the far it can swing forwards. Here, the patient's stance, the stride length is also less. And at the same time, when she's attempting for a swing, the feet is not propelling forwards. So what she does for this, if the propulsion is not taking place from the feet, she invariably do a circumduction. She will not have hip flexion also. Hip flexor is also weak. I told you already. So what is already available in them? Hip abductors are good. So what they do, they abduct and then they take it as a circle. Use a passive momentum to do a circumduction. That is a major reason for that. Look at this guy. What is his problem? The foot is flat. I told you already, when the patient is walking with a flat foot, the ground reaction force is also less. And again, the swing is going to be affected. You can see here very clearly there is a heel off and toe off is going to take place. Here, this person is having a flat foot. So this is second. This is another thing we have to know. We have already discussed it. Some people try to reduce their center of gravity in terms of fear of fall. So what they do is they slightly bend their knee. They bend their knee by means of that. What they do is they lower the center of gravity and they walk with slightly flexed knee always, which is again a mechanically disadvantaged walking. And the energy cost for this is immense. Second thing, many people would have experienced buckling when they are walking with their hip extended, knee extended. So fearing for this buckle, they used to walk with a flexed knee. Walking with a flexed knee for a prolonged period of time, loading the knee in a flexed position for a prolonged period of time, what happens is the patient will lose their terminal knee extension. And if the therapists go and work on this patient after 6 months, this bringing about the knee extension passively itself becomes a big challenge. And active knee extension most often is not achieved if this is practiced for 6 months. Okay, so knee flexion, walking with knee flexion is another headache for a physiotherapist. What do you observe in this patient? What do you observe in this patient? Anybody who is giving a right answer will get 10% exemption from the next MRA program. Whoever is answering correctly, I will recommend them for a 10% reduction in the fee for next MRA program. Any program it may be, taping or whatever Saurabhji told. Okay. Shall we wait? Postural abnormality. Be very specific. What is that postural abnormality? Plantar flexion? No. See, we are observing from the frontal plane. When we are observing from the frontal plane, you can't say the sagittal components. Okay. Forward lurch. Again, forward lurch where you can see from the sagittal angle only. You can't see from the frontal plane, right? So knee extension limitation. Again, knee extension can be seen only from the sagittal angle. Pelvic hiking. Lakshmi has said correctly, but I want her to be more specific on whether the hike is more or less. The stroke patient is doing exaggerated hiking or poor hiking. Is there any other appropriate name for that? Again, dorsiflexion also can be seen. Dolly, you can't see dorsiflexion from a frontal plane. Okay. Yes. Okay. So I would recommend giving a 10% reduction for Lakshmi in next MRA program. That's a very good answer. See, you can see this very clearly that you need some sort of pelvic tilting that is going to happen when a normal person is walking. Okay. So this lateral pelvic tilt, you see, this person is not at all tilting his pelvis, whereas there is a good amount of tilting that is taking place when we walk. Uh, and this tilt is very, very sufficient, and it gives a good amount of freedom for the swing phase. For example, here, the right leg is swinging. If there is a tilting that is happening, this gives a good momentum for the right side limb to operate freely. Ground clearance is going to be very easy. Whereas if the tilting of the pelvis doesn't take place, the leg doesn't have the room to go for a ground clearance. So what it has to do, it has to either flex the knee too much, or it has to just drag it like a flat feet. So the pelvic tilt is very, very important. And you can also see the base of support of this patient. Here, the patient walks with a very narrow base of support because she's very assured of her walking. And here, this patient is not having a narrow base of support. Instead, he's having a broad base of support. You can see her shoulder drops onto left side when she is tilting the right side. Whereas you see this guy, he is not having any tilting of the shoulder. So what is the important of tilting the shoulder? Tilting the shoulder will reduce the line of gravity, so center of gravity towards the left side, and it gives a good amount of balance to the patient. And the trunk dissociation takes place. What is meant by trunk dissociation? When I reach to the right side beyond certain limit, my left side tries to control my right side of the body. When I reach forwards, my both lower limbs flexes to control my forward expression. So the opposite side trunk, that is right side and left side trunk, work in cooperation for executing some movement. My upper trunk and the lower trunk work in coordination to execute certain movements. So this inter-segmental coordination of the patient is lacking. So my dear young students who are observing this presentation, there are certain things you can see from a sagittal point of view. There are certain things you can see only from the frontal plane or the coronal plane point of view. We are seeing the patient from a frontal plane or a coronal plane. We can see only the hip excursion that is taking place, shoulder position. So the bilaterally, whether it is symmetrical or not, that is what we can see from this particular point of view. Only when you observe a patient from the sides, you can look into the hip flexion, knee flexion, dorsiflexion, right? Hip, shoulder flexion, whether it is taking place or not. So logically thinking, if you observe a patient practically, you will understand what are all the things you can look from side angle and what are all the things you can look from a frontal angle. Okay. So when you're answering, you have to keep this thing in mind. I don't blame you because you have not got the opportunity to look into people. But now from here on, start looking into normal people more. Then only you will know what is the abnormal people wrongly doing. Okay, next. Now we have discussed about all the problems. If you want to discuss any other problems, you can discuss. We can go for a 5 minutes break. And then we can be back. You can ask me a lot of questions. The next session is going to be on training gait for the stroke patients. There will be a 5 minutes break.
It's a 5 minute break. So all of you can prepare with your questions, and sir will be joining after 5 minutes. Thank you.
Welcome back. Hope all of you are back. Now we are going into a very important aspect, that is management. Most of the time, what is a problem? People talk too much into assessment, but they don't talk much into the management aspect of stroke. I would always ask my patients, or ask my students, one question is like, do you want to see a difference in stroke patients? Do you want to progress these stroke patients, or you want to show off all your gadgets to these patients? Because most of the time people says uh, advanced training for stroke. They always land up in with some gadgets, some sophisticated tools, some unnaturalistic way of teaching, training stroke patients. I told you that it is a biological approach. So when I say biological approach, the normal behavior of stroke patient is very, very important. That is to be taken into consideration when you are training these stroke patients. So keep that thing in mind. I'm not going to give you something which is very sophisticated. I'm not going to tell you about robotics or about virtual reality or augmented reality or anything that is too way beyond the accessibility or feasibility of normal physiotherapist who is working at the society level. I'm going to tell you things which are feasible, accessible, and affordable for all the physiotherapists. And that is going to bring about a meaningful change. The first goal of any gait management should be making the limb bear the weight. So that when I say making the limb bear weight, can be of two extremes. The patient may not be willing to load the limb weight at all. When you make the patient stand, he may just lean onto you. He may fall onto you, failing to put weight on the affected limb. This is one scenario. The second scenario is the patient may have a difference in weight transmission. If you make anybody stand on two bathroom scales, okay, you know what is bathroom scale? It is a weighing machine. So you make the patient stand on one leg on a bathroom scale, another one on another bathroom scale. You can see that these patients bear less weight on the affected limb and they bear more weight on the uh, unaffected limb. So this is a poor scenario. Of course, we also stand in similar way when we are waiting for a long period of time. We tend to change weight onto one side of the leg. We keep shuffling between two legs. But when you are intentionally standing, we don't stand like that. We stand with weights equally distributed onto both the legs. But these patients don't do that. They either don't do the shifting of the weight from right to left, or when they are standing, they put a very poor weight on the affected limb. So making a patient bear weight on the affected limb is going to be a major issue. See now, here, so when we promote lateral pelvic tilt, so if only the pelvic tilt happens, the patient will put weight on the affected limb. If not for the pelvic tilt, the double limb support period will always be increased. So first thing you have to promote is the lateral pelvic tilt. You have to promote this without any doubt. Then only the patient will put weight on this limb. Okay. So how you do this lateral pelvic tilt is by making the patient lean onto the wall, which is absolutely important aspect of our day-to-day life. We always lean onto the wall. Though these pictures may look for a stylish purpose, they are leaning onto the wall. But apart from this, also on a day-to-day basis, we do lean onto the wall when we are waiting for some people, when we are doing some work, when we are reading also, we tend to lean onto the wall. So it is not something which is unnatural. So make the patient lean onto the wall with the affected side towards the wall. When they are leaning on to the wall with the affected side, definitely their paretic limb will go for weight bearing. This is one way of loading. So apart from this, what else you can try is making the patient sit with both feet on the ground. Ask him to reach with both hands onto the affected side. So when they are reaching onto the affected side, naturally their affected limb will be bearing weight. For example, if this is my right side, you are seeing the mirror image. My right side lower limb is paralyzed. So I clasp my both hand and I reach beyond my arm's length towards my right side, diagonally. So what happens is my affected limb loads weight naturally. So when the patient starts loading this leg, their motor programs on this loading keeps activating. Uh, because the problem with stroke patient is not only the muscle weakness, but also the lack of recalling the programs. There are a lot of programs, motor programs that are embedded in your brain, right? For example, if you want to reach out to the loft, you have a motor program. If you want to reach out with one hand, you have a program. If you want to reach out with both hands, you have a program. If you are going to draw a larger object, you have a program. If you are going to draw something which is sharp, you have a program. If you are going to take a glass bottle from the loft, you have a different program. So all these things are programs. They are programmed in your brain. After stroke, what happens? These programs are erased from your brain. So the patient feels like they don't have any strategy to take that, perform that task. Apart from weakness, this is the major problem for the stroke patients. What is that? The lack of programs, the lack of choices for doing functional activity, because all these things are stored in your brain and the brain has gone for some challenge and these things have been washed out. But how to recall all these things? By means of triggering one program. Like example, when you are memorizing a paragraph, when you are sequentially memorizing a paragraph, after one paragraph, you forget the second paragraph starting. So when I say the first two letters or sentence of that particular paragraph, you will recall them. Oh, yeah, the same thing. And then you will just tell me the entire paragraph. Likewise, when we are reciting some poems also, we struck in between. If somebody help us with that one particular word, then we recall everything. Same thing that is happening in case of a stroke patient also. When you load the affected limb in a very easy way, like sitting and reaching onto the affected side is one easy way of loading the affected limb. So when you do this, what happens is, what are all the programs that involves loading of this limb can be slowly revoked. It can be relearned, not learned. It can be those programs will start running without any difficulty. The brain starts recalling all these programs. So seated reach towards the affected side with both hands clasped beyond the arm's length is the very easy way of loading the affected limb. You can all sit in that position and you can try that, and you will see that your affected limb is working. The affected limb will work in a concentric manner. Okay, so patient is feeling very challenging. He is not able to reach onto the affected limb. Then what you have to do? You have to shift it to the normal side. Ask him to clasp the hands and reach onto the normal side. When the patient is reaching onto the normal side, naturally the left limb, naturally the affected limb, that is my right side, will also work, but it will work in an eccentric manner to stop this excursion. Okay, again, your affected limb will work. So these are all various different types of strategies you can use based upon patient on patient basis. Okay, so ultimately, you can also make the patient stand on a weighing machine and emphasize him to increase the weight on the affected limb by means of looking into the weighing machine and saying, see, I want you to bear 10 kg more weight. You just try to push with your affected limb. Don't say affected limb. You're trying to push with this limb onto the weighing machine. This is getting a biofeedback for the patient, and the patient sees the feedback and he tries to push it and he maximizes his efforts. So these are the different ways of doing it. Okay. Next is how to initiate loading. In standing, if the patient is having buckling, if the patient is not very sure about the knee, you can give him a knee brace. This is according to MRP, that is Motor Rehabilitation Program, Relearning Program. Karen Shepherd always educates the patient to wear a knee brace, which I also agree, but we have to just wean out of this knee brace as early as possible, because there is a huge amount of dependency that the patient will develop. That is why I have never told you about any walking aid so far. I have not asked you to use a quadruped or a tripod or a frame or whatever it is. I have not told you anything about it, because this will first thing will reduce the potential of the patient. The patient will start depending on it, and they become habituated to that, and without which they will never walk in future. So that again, we are giving him an abnormal behavior. So I really don't want that. But in case if the knee of the patient is very wobble, and you feel like a week of knee brace will help you. Don't use a knee brace more than a week or two, and slowly try to wean it away from the patient, and keep telling the patient that this is not going to be permanent solution for you, and I'm going to slowly remove this knee brace. Okay, so then only you can walk better. So that you have to keep emphasizing on the patient. See, now this here, when you're instructing the patient to walk, when you ask the patient with the knee brace, you step your normal leg forwards, he will step very small distance only. But if you give him a target like touch my feet, or move your leg towards my as if you're touching my feet, or give him a floor marking at what distance you want him to reach, will definitely maximize the patient's effort. Because these patients will always be conservative. They want to conserve energy, they want to be risk free, they will always have the fear of fall, and they'll always be having the exhaustion. They'll be always in a tired state. So you always give them the target, a target which is feasible for them, which is achievable for them. Don't give them some abnormal, unachievable target. Like ask here the patient is asking, touch my shoes. So he is increasing his distance. You can see that very viciously. Next is loading the paretic limb. How to do loading from the other point of view. Step up and step down exercises are very useful exercises where the patient dynamically loads the paretic limb. All these time we have seen static loading. Now the patient dynamically loads the limb. See, now the affected limb is stepping, and with the knee flexed, he goes for a full standing, and then he slowly steps down. Step up and step down will both work the muscles of the affected limb concentrically, isometrically, and eccentrically, and uh, that is a very, very important function for dynamic loading. Lateral stepping is also a very important thing. The patient, if this is also going to re-educate his lateral pelvic tilt, and how to slightly bend the knee, that is a loading knee, to achieve the lateral bending. Lateral stepping is also a very good challenge for the patient. So you can adopt these things. Next is heel raise and lower from a step. See now, heel raise and lowering. He's standing on a step, and then he's raising his feet and lowering it, and with the help of a chair in front for his balance. Initially, you can do this, and then you can see this here, the knee is bent. So this is not the right way the patient should do. You have to emphasize on extending the knee very importantly, because by bending the knee, he can give an image like he's doing a dorsiflexion. But in fact, here he's not doing a dorsiflexion. In fact, what he's doing is he's doing a knee flexion, and he's giving an image as if the dorsiflexion is taken place. Okay, so emphasize on knee extension and doing a plantar flexion. And now this is, you can see the muscle is weak, but when the patient is doing it from dorsiflexion and he is pushing his body up with one leg without the support of the other leg, that's when his knee is going for his calf muscle is going for a strengthening, and that strengthening is going to happen very effectively. Once the strength is trained, then you train him for the power. What do you do for a power? When I say push up, the second you have to push it up. So that is how you have to give a reinforcement. Your words should be very sharp, and the movement should take place very fast. If you normally ask a stroke patient to go from such dorsiflexion to plantar flexion, raising their body up, they do it very slowly. So that is not going to help when the patient is going to walk faster. So what has to happen? It has to happen within very fast time. So you use sharp word. Come on, now if I tell you to push up, you have to do it fast. Okay, these sharp words will really reinforce the patient to do it very faster. Okay, so strengthening and power training of the calf muscle is very, very essential. You can see the trick movement, hip flexion, as I told you, able to contract the calf. No trick movement is involved because the knee is in extension. And now strengthening calf after activation of the calf muscle. Now the patient is doing a single limb extension. And followed by this, what you have to do is power training. Difference between the strength and the power is the time quotient. In the power, you have time. In strength, you don't have the time quotient. Now, what if the patient is not able to stand, or if the patient is very apprehensive to do a heel raise? What you do is you have to make the patient stand on a wooden block. You imagine this is a wooden block, and this is another surface. So make the patient stand with half of his heel, half of his foot on a wooden plank, and then half onto some other surface. What you do is you ask the patient to do a heel raise. If the patient, most of the time the patient won't be able to do a heel raise, but he will be doing it on the affected limb, unaffected limb. Okay, in this position, the patient will be able to raise his heel only on the unaffected limb. The affected limb will not raise because it is weak, but the loading on the affected limb will be less. So what you can do is slowly you can withdraw the wooden block. Once you withdraw the wooden block, the patient heel will not drop. You just test it on a stroke patient. The heel will not drop. The patient on an anticipatory basis will contract the calf muscle and hold it in that position. So from this position, ask him to go for a heel raise. Got it? Again, I'll tell you, make the patient stand with half of his feet on a wooden block, half of his feet on a concrete material. Okay. Ask the patient to do a heel raise. Ask him to go on his toes, in which the patient will be able to successfully do it with the unaffected limb, but the affected limb will not raise because he is very weak. But again, that affected limb will not transfer much of weight onto the lower limb. So what you can do is you can easily withdraw remove the wooden block. So only the patient is standing with half of his feet on the concrete material, but the patient will not drop his heel down when you pull it. Anticipatory muscle contraction will be there. So he will stand with his feet on the concrete material, and his heel will be completely away from the ground. From this position, ask him to do a plantar flexion. Ask him to do go on to the toes. He'll be able to do. So this scenario you have to use for patients who are highly not weight bearing. Okay. Any doubt? Hope I have explained it correctly. In case if you have any doubt, you can ask me. So far clear? Shall we progress to the next level? So all these time, what we are seeing is how to make the patient load the affected limb. And we are also seeing how to bring about calf muscle super contraction. Okay. So next. See, from make the patient stand in this position. Next is to contract the calf muscle from a mechanically disadvantaged dorsiflexion position. Try contracting the calf from a stretched position from here. If you ask him to do from this position, this is again going to strengthen him much. Now, what is here? What we are doing here is loading the affected limb, and we are executing some functional task where your trunk bends forward. This needs a lot of confidence. Even normal geriatric patients will not do this movement, fearing about the fall, and that too a patient with stroke will find it very difficult to do this task. So what you have to start with is keeping the target, reaching target slightly higher in height, like here. We have kept this on a tipoy or a wooden stool or somewhere, asking him to slightly bend forwards, and the affected limb is the left side. It is the one which is forward, and it is loading the weight. Now he's bending forwards, and his entire body weight is getting shifted onto the affected limb, and he is picking up the object, which is fairly not onto the ground, it is on the chair. Okay, and you can see this guy, he is adopting a abnormal posture. He is keeping his feet on a straight stance and he is bending forwards. Every possibility of him tipping over is highly possible here when he is reaching down. Instead, what he has to do is he has to adopt a walk stance, not a straight stance. Okay, fully loading the affected limb to perform a task. Here, advancing to pick object with a wide base of support with feet parallel. You should not encourage the patient to do and forward bending with feet parallel, because they will not be having a proper hip and ankle strategy, and definitely they'll tip forwards. See here also, doing the same with a narrow base of support and a tandem stance. So tandem stance is somewhat preferred compared to a parallel standing. Now, sit to stand training to increase loading. Sit to stand is a fantastic exercise, which most of us don't do it very frequently in the correct dosimetry. If at all, if you see the literature of stroke patients rehabilitation, sit to stand is one activity which is being researched so much in research, and it has a lot of health benefits. Like how we encourage squats and sit to stand for a normal person, stroke patients also involuntarily load their affected limb when they are doing sit to stand, because it is there in their program. Lifelong, they have been doing sit to stand, and that is a very important program which is deeply embedded into the brain, which can be evoked very easily compared to some of the tasks which rarely the patient has done. Right? Here I can give you an example, like comparing driving a cycle and swimming. So for a person like me, I have driven cycle throughout my life. Still I am cycling, but swimming, I get a very, very rare opportunity to swim. Whenever I go to the water bodies, I swim, and I am not a very good swimmer also. I know to swim, but I'm not a very good swimmer. In fact, some of my scholars taught me how to swim recently. So cycling, if I have some problem in my future, if I get a stroke in my future, rehabilitating cycling is going to be very easy for me than swimming, because first thing, I have not used swimming for a long period of time in my life. I have not frequently practiced it. Second thing is, I am not a master in swimming, whereas I know cycling very nicely, and I have been repeatedly cycling throughout my life. So likewise, if you see the sit to stand task, every individual invariably in their life would have done this for lakhs and lakhs of times in their life. Re-educating the limb loading through sit to stand is much easier than any other task. So make the patient to do sit to stand very frequently. Obviously, he will start bearing the weight on the affected limb. Okay, sit to stand and stand to sit is also very important. Now we have completed the goal of loading the limb. Second goal is to prepare for swing. Stance phase is over, now swing phase. So in swing phase, there is a big challenge. What are the big challenges? Initial swing phase in the paretic limb. What is influencing this initial swing phase? I told you that the calf muscle activation, as well as the hip flexor's ability to contract and swing it forwards, is very badly affected. Now, what we want to encourage now, heel off. The patient walks with a fat foot, so we want to encourage the heel off of the patient. So what we do is, the therapist position the limb with the heel on, heel off position from a wall. Imagine I'm standing in front of a wall. I'm facing away from the wall. The therapist take my affected limb and keep the heel on the wall behind me. Okay, and my toes are in ground and the heel is in the wall. So now, if I swing from this particular position, it is like I'm swinging from a heel off position. Am I right or not? Imagine I'm standing. I'm standing with my back towards the wall. Okay, and my affected limb is right side. So what I do is I keep my right heel on the wall behind me. and my toe is on the ground. So my left leg is forward. So what it looks like, my left leg is like that, my right leg is in a heel off position. So from this position, if you ask the patient to swing forwards, the patient will swing with good amount of propulsion. So likewise, you practice it for many times, and then the patient will walk with the heel off. So we then again you take the patient to the walking surface. You ask him to emphasize him more of heel off, or in case if he's not doing it, you sit down and re-educate that movement with guided movement. You do a heel off and toe off. People do it very easily on a treadmill, but using a treadmill has a lot of disadvantage in stroke rehabilitation, because there are so many documentation research that are available that walking on a stable surface is different program, and walking on a moving surface is a different program. If the patient is very much used to walking on a treadmill, then well and good, you can put him on a treadmill and walk. But a person who, in an Indian scenario, if you see, 80% to 85% of the people might have not even stepped into a treadmill once in their lifetime. So such patients, putting them onto a treadmill and making them walk is not relearning, but it is a new learning for them. It is going to be new learning. Such new learning, your brain gets into confusion because already the brain is in a problem, and you are giving him a much more challenging task to do. I will give you an example. How many of you have taken your parents to an escalator or to a treadmill? Your parents find it very difficult. They prefer going through a lift or through a staircase rather than going through an escalator, because all these days in their life they have not practiced it. Normal people also find it very difficult, and imagine about a stroke patient. So there are a lot of disadvantages in putting a stroke patient onto a treadmill. If it is highly needed, please try that. Otherwise, use your parallel bars, which are far superior than the treadmill. Okay. Now, this is the position. You can see, you can read therapist position, the limb with heel off position from where the patient attempts a swing phase. Use the wall for positioning the heel. I think you have got it. You can also have a wooden block under the patient heel, mimicking that he is doing a heel off, and then you can ask the patient to swing from that particular point. Then partial weight bearing walking. So I told you this as an example. Here, this is one type of intervention that was taking everybody's brain by storm during the 2000. When I was doing my PG, this was a major intervention which breakthrough partial weight supported walking, and many people invested too much onto this. But the realistic transformation from a partial weight bearing walking to a complete weight bearing walking, there are a lot of challenges. So it's highly controversial. For a Western population, this is fine because they mostly do treadmill. They are got used to treadmill and they are very educated. But and in the Indian scenario, it is very tough for making a patient getting used to a treadmill. Okay, so you can see here what are the positive things for which you can use a treadmill in an Indian scenario. I would say is bringing about a good amount of dorsiflexion, a good amount of heel raise, because the platform is moving. If the patient is not attempting, the platform will drag the leg backwards. So obviously there will be a beautiful heel off and toe off taking place in this particular manner. You can see this patient. Then is hip extension is promoted very nicely. Because the moving platform, if the patient is going to take some time for the heel to the feet to move forwards, by the time the moving platform will take the hip for extension. So patients who are walking on a level ground, the same patient walking on a treadmill, the major difference is the hip goes for extension because the platform is moving. So this is one advantage with a treadmill. And also it increases the walking speed of the patient, because anyway, the speed is determined by the therapist. The patient has to get used to that. And the body of the patient weight is being supported by something else. So his feet are very free to move faster. And this also increases his cardiorespiratory endurance. So for these purposes, you can use treadmill. But patients who do not transfer their weight onto the lower limb. If you train them with a treadmill, it is very difficult for them to transfer the same treadmill activity into level ground walking with their body weight supported onto their lower limb. Okay, so this you have to be very careful. Sequentially, when you're training, first thing you have to train is stance phase, and subsequently you can train for a swing phase. If the stance phase is poor, swing phase quality will also be poor. Training it will give more compensatory patterns, uh, training the otherwise. Okay. Now, next thing is activating dorsiflexion with the knee and hip in flexion. This is a very challenging task. It's a very, very needed task, because when in the terminal swing, you can imagine the terminal swing, the hip is also in flexion, knee is also in flexion. And in this position, if the dorsiflexion doesn't take place, what happens? Ground clearance becomes a big difficult task. So very simple thing is make the patient sit on a high sit in this position. Just diagram shows you in this position. Ask him to raise the hip and knee frequently with resistance. This will concomitantly bring about dorsiflexion. How I am saying is it's a program. It is a program where triple flexion is a programmed thing in your brain. If this is not working out, you ask the patient to lie down on the edge of the couch with the affected limb out of the couch, ask him to lower the leg down, and then again lift it up and keep it on the desk. Okay, he's lying on the edge of the couch with the affected limb suspended down in supine lying position, and the affected limb will go down and touch the feet floor, and then it will come up and lie parallel to the unaffected limb. So this is also one more activity. In case if you are not getting all these things, again, kicking is a very important activity. From a hip and knee flexion, dorsiflexion and knee extension takes place concomitantly. The patient will beautifully kick. Kicking is one activity everybody would have done in their life. Okay, this also diverts the attention of the body weight. The patient is not worried about the body weight. He's worried about only the kicking the ball. Initially, the kick will be feeble, but as time progresses, the kick is going to be much more stronger, and the patient targets more on hitting the ball faster rather than their balance. And this can also improve the balance. And this can also improve the dorsiflexion. If you are using a hard ball, there are possibilities of injury, but if you are using a soft ball, there is possibility of injury is very less, and motivation of the patient will also be there. Okay, so first thing what we saw was increasing the loading of the affected limb. Second thing was preparing for the swing. Third thing was doing dorsiflexion in a hip and knee flexed position. So what are the targets? What are the advantages of giving a floor marking on the targets, which we have already seen? This increases the step length and activates the hip flexors much more, and it also activates the dorsiflexors. In order to reach for the target, they do a beautiful hip flexion, and we have already trained the dorsiflexion in hip flexion. So naturally, more the hip flexion takes place, more will be the dorsiflexion taking place. And it also increases the gait velocity, and it reduces the cadence, and the energy cost for walking is going to diminish if this is going to continue. So give floor marking like this, targeted walking. Now, avoiding circumduction, which is a major problem, which is a very abnormal behavior patient learns over a period of time. Apart from the previous efforts, what we are taking during the swing phase, a fair amount of education should be given to the patient. Education about the circumduction and why it is being done. You think patients are not educated, and you think that educating the patients are no, it's not going to be effective. We always say, don't bring the leg in this manner, don't bring the leg in this manner, but we don't tell patients why he is adopting that behavior. You have to educate. Once you educate the patient why he's adopting that behavior, there is a self-realization that will take place, and the patient will try to take an effort towards walking on a normal hip flexion. Keep a stool or anything, an obstacle on the lateral side of the patient, and you have to tell the patient that you have to walk without hitting this object. So what happens is He will not try to do a circumduction. He will not try to do an abduction. After explaining, you have to do this. So when you are asking him to walk very close to the wall, telling him that you should not hit the wall, you have to walk straight. This will reduce the circumduction. Fair amount of circumduction will be reduced. Okay, you have to ask the patient to walk very close to the wall with his affected side towards the wall. And in case if he's doing an abduction, it will hit the wall. In that scenario, you have to make him walk. In that case, the patient will stop doing a circumduction gradually, not immediately. But there are chances of patient doing a hyper exaggerated pelvic tilt to the affected side. He will dip the pelvis onto the unaffected side and he will hike it on the affected side. But that also you have that behavior also you have to discourage and you have to make him walk. Next is directional walking. Very importantly, side walking and back walking are also part of gait training of stroke patients. And you observe this patient, she is holding onto the rails of the bed and she's attempting to do a walking onto the sides. Okay, so what is the problem with her is when you do side walking, one leg is being loaded, another leg is being relieved, and that should happen over a period of time. And in the picture A, you can see she steps forward with her left leg rather than holding her line of propulsion. So she has to move sideways, but she's stepping forwards. So what you can do is you can draw a line like this. Yeah, I think you can see this line. You can draw a line like this and you can say that the patient, you have to follow this line. Your feet should not go beyond this line. In this line of direction, you have to propagate. So the patient will step accordingly. Because this tend to stepping forwards is because of lack of lateral stepping strategy for the patient. The patient will always try to propel forwards, for which she has been trained all these days. So lateral stepping, you have to re-educate through a target on the floor. Again, walking backwards is also a very good exercise for the hamstring muscles because hip extension and knee flexion are both done by the hamstring muscles, which is rarely trained. In stroke patients, there are studies which states the amount of concentration physiotherapists give for quadriceps, they don't give for hamstring. In that case, they also don't, even in a sports rehabilitation also, the amount of concentration that is given for the hamstring is very less compared to the other muscles. But hamstring is a very important component of walking because it brings about hip extension and knee flexion, and back walking is a very good exercise for that particular muscle. Now we have activated the stance phase, we have activated the swing phase, but now it is time for us to strengthen them. It's very important, you have to strengthen them. So what you do is, you normally prefer single muscle strengthening. Am I right or not? Normally, for us, strengthening is single muscle strengthening. Why doesn't single muscle strengthening help in case of stroke patients? So now here you see this guy is using a TheraBand to strengthen his calf muscle. Now you see the below one is a lady is giving a manual resistance for the lower limb, knee flexion and extension. And you give a towel below the knee roll and do a quadriceps drill, which is a very famous exercise we do. In a lying position, the bridging, what we do for hip extensors. All these things are not going to work out in stroke patients in strengthening the pattern. One simple example I'll give you. There are patients who are not able to do knee extension from a high sitting position. Patients who are not able to do isometric quadriceps contraction with a towel below their knee, who are not able to do quadriceps drill, but when they are doing a sit to stand activity, that quadriceps contract. EMG studies have proved this. You might be asking me a question: how come in an open kinematic chain exercise, the patient is not able to contract the quadriceps? In a gravity elimination position, the patient is not able to contract the quadriceps. Then how come in a closed kinematic movement, that too with the body reinforced on the patient's lower limb, how he's able to stand and how he's able to contract the quadriceps? That is because of the motor programs. Apart from the weakness that is seen by physiotherapists on stroke patients, there are some amount of programs that are very, very importantly lost in stroke patient, and some of them are still preserved in stroke patient. If these programs are, what is one single program? Single program is nothing but chaining up of all muscle activity to attain one particular task. If this program is run uh, without the conscious control of the patient, the quadriceps contracts. So now you tell me, what is the exercise you have to rehabilitate in stroke patient? Is it single muscle exercise or an uh, uh, a combined close kinematic chain exercise like sit to stand, squatting, lunges, all these things that has to be re-educated. You have to decide on your own. Always go for a close kinematic chain exercises which are task oriented, which the patient has already performed too many times, like sit to stand, sitting and standing from a ground or a lower couch or from a stool or from a chair or from a toilet commode or from a parking chair. Uh, all these things are the one which the patient has done so far that can strengthen his knee more compared to such single joint exercises. Don't waste your time on these things. Next is eccentric contraction. Initially initiating eccentric contraction is very easy. The very common question I face in such presentation is, sir, what you do for an acute phase? Can I follow Brunstrom's technique? Uh, you say no need of giving passive movements to the patient. What I will do in case of an acute stroke patient who has no tone, no reflex, flaccid, everything is floppy. Try to bring about eccentric contraction. If the brain is in cerebral shock, nothing will work out. Definitely. What is cerebral shock? Time after the stroke, the brain is going for a shutdown. Most of the major functions of the brain on the affected limb will go for a shutdown. This is much similar to a cerebral shock, spinal shock. Only when the cerebral shock resolves, slowly the tone starts building up in the muscle and the brain starts establishing its control on the affected limb. Until then, what you can do is you can remind the brain about the lost function. For that, eccentric activity are tremendous activity. For example, holding the leg in this position, supine lying, and slowly lowering it down is a fantastic exercise, eccentric exercise for the hamstring. And this thing can bring about a concentric contraction of the hamstrings very soon. Okay. According to MRP, he says that Carr and Shepard, they say that this this hamstring contraction from a prone lying position can be translated into standing position. But in my experiences, I have always found it this translation doesn't take place. Activity which is trained in prone lying, it takes very difficulty with a lot of difficulty only we can translate it into standing position. So now the concept is changed. If you want the patient to do a good walking, make him walk. That is the best exercise. Don't prepare him for something like this in prone lying and then translate that into standing position. And that is not going to work. Very significant example I always give is when you want your child to go for swimming, or if you want to learn swimming, if you want to be a very good swimmer, what you do, you go to the gym, you do exercises, you increase the power of your scapular muscles, you increase the power of your hip flexors, hip extensors, you breathe, you do breathing exercises, and then you will you get into the water and you become a good swimmer? No, you can't do that. What you have to do is you have to get into the water. You have to get into the water and you have to practice all these things in water. The real life scenario, the real swimming scenarios, you have to practice back strokes, front strokes, open strokes, all these things you have to practice. More you practice, more you get the speed, more you swim faster. So likewise, when you want a patient to walk, if you make the patient lie down in the bed in prone lying, supine lying, side lying, sit on the Swiss ball, strengthen, and then you expect the patient to walk faster or walk with good cosmetics, that is not going to happen. Only when you give the opportunity for the patient to walk and give him the right behavioral changes, he is not going to walk. So in this area, I contradict the Karen Shepherd theory of motor relearning program. Also, the training of the missing component and translating the missing component into the task is not that easy like how Karen Shepherd mentioned. So that is where the functional biological approach differs from the Karen Shepherd's approach. Now, the most important part is most of the lower limb function task requires eccentric control. So eccentric control training is very, very important. I told you before, translating from eccentric to concentric contraction is very easy, but eccentric control is also very, very important because when you are doing stepping, when you step down with your normal leg also, the affected leg has to slowly contract in eccentric manner to translate the normal leg down. So the unaffected limb performance is also heavily dependent on the eccentric activity of the affected limb. So training the lower limb for concentric activity is not sufficient. You have to train it for eccentric activities also. Now, I'll give you a workout now. Now, when the patient is sitting in this position, okay, if the leg is moving, when you ask the patient to load this limb, so now his left limb is the one which is affected limb. Okay, I just want to know the analytic capacity of the people who are attending this program. He is asked to load his affected limb. Okay, in this position, if he is not able to do this loading and instead his leg goes for extension, knee goes for extension and his leg move forwards in this direction, what is your observation? What is your observation on this patient? You are asking a patient to load weight on this weighing machine. You ask him to increase the load by 20 kg, but the patient is not able to load this limb. What he does is his leg translate forward instead of doing vertical pressure. What is your observation as a physiotherapist? Physiotherapy doctors. Knee flexor weakness. Fantastic answer. How do you say knee flexor weakness? How do you say it is a knee flexor weakness? Why? Because of knee flexor weakness, why this happens? Lack of shortening of posterior chain muscles. This is very tricky. I'm not aware of this thing. The knee goes into extension. What Siddhi is saying correct. That is the correct answer. The hip flexors are so weak. Knee flexors are so weak. The hamstrings are so weak. So the quadriceps is strong and it is taking over the unopposed action of the quadriceps is the reason for this. Okay, and as someone said, weaker muscles are compensated by stronger muscles. You can say it in another way that the weaker muscles overrides the stronger muscles override the weaker muscle. It is not because of the quadriceps weakness, Arpit. It is because of the hamstring weakness. The quadriceps is strong, the hamstring is weak, so normally the limb goes for extension. Okay, now second question I'll ask you. In this question, if you ask him to do this, I have written the answer, quadriceps action unopposed. So that is the reason. Second thing is, if the heel is going for raise, instead of pressing, his heel is being raised, then what is the reason for that? The same patient, when I ask him to load weight on the weighing machine, he is raising his heel instead of pressing it down. What is the inference for a physiotherapist? Tight soleus. Okay. If there is a tight soleus, the patient will not be able to keep the leg also in this position. So the passive position is not the problem. Hip extensor weakness. No. Push off from calf. Yes, why that push off from calf is taking place? Yes, dorsiflexor weakness. I'm not able to spell that word. I'll tell this name as Priti. Okay. Finding it difficult to read the name. Car, Priti Car. Okay. Uh, because of the weakness of the dorsiflexors, the plantar flexors overact and they produces a plantar flexion. So simple, logically thinking. Okay. Good. If the heel is lifted, plantar flexor unopposed by the anterior tibialis. So you can easily test which is the muscle that is having the problem. Now, activation of the quadriceps is a very important thing. I told you already, from a high sitting position, whatever quadriceps activation you are doing, they may not get transferred into standing. So instead of that, what you have to do is you have to do sit to stand training. But as a part of strengthening the quadriceps muscle, increasing the bulk of the quadriceps muscle, yes, you can put the patient with weight, initially making him to hold this weight and slowly lower it down so that you are activating eccentrically the quadriceps, and then asking him to contract, and you can increase the muscle bulk with this movement, strength with this movement. But if you ask me whether the same thing will translate into walking, again, it's doubt. Flexibility exercises. Normally, when I say flexibility exercises, people will say passive range of motion, passive stretching. All these things are flexibility exercises, which we encourage for the patient. But when we do that passively, flexibility exercise for some patients, for these patients, we normally hurt them. We injure their soft tissues because they are already weak, because they are not properly loaded, and there is lack of flexibility of their muscles and the ligaments and all these soft tissues. When we do passively, we will hurt them. So what is flexibility exercise for stroke patient means? No passive stretching. Okay, what you have to do is you start with half squats where your hip, knee, ankle all are strained. It may be an assisted squat or an unassisted squat, but you have to do half squats. Later on, lunges. Then walking on ramps will increase the range of motion, flexibility of the ankle, and then long steps will increase the flexibility of the hip joint. Okay, these lunges and half squats will increase the range of motion of the knee joint. So these are the flexibility exercises for the stroke patients. Don't think too much beyond that and put the patient in supine lying and stretch him so badly that he starts screaming. We have seen a lot of Facebook posts from few people where the patient starts screaming when the patient starts, therapist starts stretching. But that is not the way you have to treat a stroke patient, because he's a biological unit. Remember, he also has emotion. He is also a human being with a lot of critical analysis and thinking. If he develops apprehension towards your management, then nobody will cooperate with you. If the patient doesn't cooperate with a therapist, whatever the ability of the therapist will be, the outcome will be zero. Okay, so patient-centric treatment, as I told you, in a functional biological approach is very, very important. Next is circuit training. Once the patient completes one task, like sit to stand, he's able to do, stand to sit, he's able to do, side walking, he's able to do, forward walking, he's able to do. Put 4 chairs, ask him to sit to stand from all the 4 chairs on a circuitry basis. So this will give him more balance, more activity satisfaction, and more he'll be moving towards the society. This is moving a patient from a clinical setup to social setup. And you varying a sit to stand circuit, like start with a tall chair, then a smaller chair, and then even smaller chair, and then a very small chair. Ask him to sit onto all these surfaces on a circuitry basis. That is also a fantastic exercise. Varying the stepping, like you make the patient step a small distance, a large distance, walking on targeted walking on the floor. That will give him target shooting very easily. Coordination of the lower limb will be there. Then comes the community ambulation. If the therapist is very satisfied, if the therapist feels like this guy can avoid the obstacles in the society, and you take him for a community ambulation. There are a lot of difference between an indoor ambulation and a community ambulation that as a physiotherapist you have to understand. Here, there is a controlled ambience. That is, when you are using in a clinic, nobody will enter into the room. The temperature will be fixed. There won't be any dust coming into the ambience. The surface will not be having ups and downs, right? When you go to an uncontrolled ambience, suddenly somebody will cross you. Suddenly there will be a dust coming fine. The patient will have the dust in their eyes. They will lose their balance. Uh, or the surface will go up and down. There will be a ramp, there will be a staircase, there will be water on the surface, there will be manholes on the surface. These things are challenge for the patient, and you have to educate the patient before taking him for a community walk. What are the things you have to train when you are taking the patient to the uh, community is walk at speeds fast enough to cross streets safely, because when you are crossing the street, uh, you have to cross at least 1.1 to 1.5 meters per second. You calculate for 10 seconds how much distance they have to travel, because they can't take all the time in the world to cross the road. It is very difficult for them. Okay, crossing the road is very, very important. You have to train. Walk for a long enough time, and as far as at least 500 meters per day in the initial stages of social ambulation, because 500 meters of social walking is equivalent to 2 kilometers of walking in a treadmill or walking inside the closed ambience. Turn the head while you are walking is a very important task you have to train for stroke patients, so that they don't get fixed on their direction, and that their fixed mentality is removed. And sometimes if the patient is so concentrated on the floor and somebody call him, he turns and then he falls. So that has to be trained. Use anticipatory strategies to avoid or accommodate obstacles. What are the compensatory strategies you can give? Is giving him a stick for community ambulation is also a good idea. Remember, I give stick only for community ambulation, not for initial rehabilitation, because that will develop a lot of dependency. React quickly enough to obstacles which are coming in your way. For example, suddenly somebody is putting a cycle in between, a car is coming very fast. How to evasively act for these things has to be taught to the patient. And in case if the patient slips forward, how to recover from a slip position, how to recover from a fallen position has to be taught as a scenario for stroke patient. For example, you make the patient go onto the floor and teach him how to get up from the floor. Okay, using the stick or using objects nearby, you have to train them, because most of the time the patient has a fall. If somebody help them to recover back faster, this doesn't stays in their memory. But sometimes when the stroke patients fall down and they lie down, and in their effort to get up, they face some more issues, problems, social embarrassments. All these things will stay in their mind if they don't quickly recover. Example, even we fall down, right? We when we are as a teenager, you guys fall down in front of girls. The moment you fall down, you get up with swift, doesn't matter. But if you fall down and you take 2 3 efforts to get up and still you're not able to get up, and everybody is seeing you and they're laughing at you, then that is a big shame for you, right? So you have to teach the patients to recover from the fallen position. Negotiate stairs, ramps, moving for footways, and carry objects. How to walk carrying objects on the both hands, because the upper limb helps them for balance by means of reciprocal arm swinging. But in case if they are constrained by means of carrying 2 kg weights on both the hands, how that is going to affect their gait? All these things are very important things you have to remember and train for the patient. Some of the pictures here, you can see the eccentric control of the affected limb is very important when the patient is stepping down. Stepping up is less challenging than stepping down, because the patient looks into the vertical depth of the walk space, and the patient is she goes for freezing often. Stepping down the ramp here, you can see, and walking on steps which are very narrow. See here, only half of her feet is being supported on the steps, and this is a big challenge for her. Then walking and bending forwards to pick objects on the floor. In case if the patient walks on the street and her mobile phone falls down and nobody is there to help her, then he has to bend forwards and lift the pick up the mobile phone. All those things also should be anticipated. And with the functional rehabilitation of the restoration of the social movements, that ends your responsibility as a physiotherapist with the stroke patient. So, my dear friends, the take home message is very loud and clear that passive intervention are not going to help any stroke patient. Your stretching, your passive movements are all those days gone by. Analyzing the patient from a functional point of view, considering the patient as a biological unit, and any task specific exercises are only going to be the way out of training patients with stroke. Intensive training doesn't mean that giving 100 passive movements. Intensive training means intensive education of the patient, intensive learning opportunity for the patient, and practice. With this, we come to the end of this presentation. Now it is open for questions. We will take up questions for the coming 15 minutes. And if the candidates are given an opportunity to unmute and ask the questions through voice, I think that would be better, Saurabh. Yeah, it's open for questions. Please ask your questions.
Okay, sir, I did, sir. Unmute.
Yes.
Yeah, participants kindly ask question. Sir, actually there is a question came to me.
Yes, sir, please.
Hello.
Yes, sir, please,
Yeah.
sir.
So there is a question came to me actually 1 hour before. The question is like, which is the best book for the gait rehabilitation? Which is the best book for the gait rehabilitation? It's a question from one of the one of the student, finally a student, because he finds very difficult when he refers. I mean, I will not name the particular book he has told, but yeah, I mean, he finds very difficult. So what is the best book? So he asked me over the WhatsApp. People are asking me over the WhatsApp also, like few of them, those who know me personally.
Okay.
So kindly suggest certain books for whatever you see.
I would prefer reading Car and Shepherd for functional rehabilitation stroke. That is a good book. Stroke rehabilitation. The book name is Stroke Rehabilitation. And also, I would suggest these people, the young people, to read into Shamwe Cook, Motor Control. The book called Motor Control by Shamwe Cook. So those two things are very good. I'll also suggest you to have a look into a book which was written by Professor Hari Om on stroke. The book name is Stroke, and the author is Hari Om. So they are I think he's a pioneer in the field of neuro rehabilitation, and his book is the one which really changed my approach towards stroke patient down the lane a decade before. I would suggest these three books for you, and once you read these three books, you will get an insight, and you will go beyond what I can suggest you. You will definitely read much more. Motor Control and Learning by Shamwe Cook, and then Stroke Rehabilitation by Carr and Shepherd, Janet Carr and Shepherd, that is Motor Relearning Program concept, and then the book called Stroke by Hari Om. These three books I would suggest.
So can I ask you a question apart from this topic?
Yes, madam.
No,
please.
ma'am. I would like to request you that kindly ask. Sir is very busy, so ask questions only pertaining to this topic. However, if you have questions, sir has permitted you. You are one of the lucky persons, so kindly ask the question. Please go ahead.
Okay, thank you. Thank you. So, what about the recovery of atonic bladder, which is resulted from a traumatic injury, L2 burst fracture? So, what about the recovery of that atonic bladder and bowel?
Now the current situation of the patient is she's having an atonic bladder, right?
Yeah, he's having L2 burst fracture. His
Burst
wings
fracture.
is almost normal, like power 3 to 4, yeah, 4 to
Okay.
5. But only the issue is bowel and bladder incontinence, which is atonic for about 8 to 9 months.
8 to 9 months. See, the spinal shock is a very important thing here. If the spinal shock resolves, then only the bladder tone will return. It is very, very unfortunate for certain people, very, very less proportion amount of people to have cerebral spinal shock to last for so many days. But we need to do some amount of investigation, like how is the bulbocavernous reflex? How is the sensation in the saddle region? How is the sensation of the S1, S2, whether it is preserved or not, to know whether the spinal shock has resolved or not. Once you see the bulbocavernous reflex is there, the sensation in the saddle region is there. In spite of that, the patient is not having a tone of the bladder. That means there is some amount of lack in the intervention. But in case if there is no bulbocavernous reflex, there is no sensation in the saddle region, S1, S2 myotomes are also negative, then that means the patient is still in the spinal shock. The spinal shock has not resolved. Unfortunately, one out of a lakh will have such problems. But I feel for a person who has got good power in the myotomes, but still doesn't have the urinary functions restored, there is some problem in the catheterization intervention, which you need to clearly analyze.
Okay, sir. Thank you so much.
Thank you. Welcome. So again, I am sorry, I didn't know the norms of MRA. Please stick on to the session now, what we have discussed, so that it will be more fruitful.
Thank you so much, sir, for your wonderful session. I would like to let know all the participants. Last year we had class by sir that was on completely biological approach for the stroke rehabilitation. I will be very happy for Chennai or Bangalore. You can let me know all of your inputs. If it is there within 1 month or 2 months, we will arrange the class. You will be given the access
Yes.
for sir other videos like hand rehabilitation. You'll be given access for this particular video, of course, in the premium, and then you'll be given, I think, one more sir has taken that also will be there with you. You know, apart from that, sir will taking complete practical class, and this class will, I can tell you, like last year, I mean, this has changed my own perspective for seeing the patient. So I would request all of you who are interested. That's just a 1-day program, 8 hours practical. So all these things will work for you. So you can just let me know about the city you want to attend, but Bangalore and Chennai are more preferred most of the time. We'll see sir like schedule also, because sir is very busy in his educational programs as well as his clinical program. Sir is very much firm believer of quantum medicine, I mean the alternative medicine, integrative medicine, and he is much natural. So you all will be amazed seeing his practical classes. So I'll be displaying now code. You all can send GT9. Let me tell you GT9 and send it to 9066990059 through WhatsApp. I'm putting in the chat box also. This is the code. So please send to 9066990059 through WhatsApp. Don't send through a normal message. Through WhatsApp, you will receive one link. Please put your name properly. Yeah, it has been displayed. Please put your name properly. So another 3 to 4 minutes, this will stay. After that, no one please ask me for the code, because those who are sticking to the program till now are only the beneficiary of the certificate. So GT9 WhatsApp is code to 9066990059. Meanwhile, I extend my sincere thanks to Dr. Arunachalam Ramachandran sir for his precious time he took out on Sunday, and the thanks is on behalf of complete My Rehab Academy, core members, and all the participants. Thank you so much, sir, for joining us. and you made this Sunday quite vibrant.
Thank
So, and the thing is, like, what we are doing in terms of stroke, we are making things simplified. Guys, please try to understand, just making this 1 hour of PowerPoint presentation and 1 hour of talk presentation, completely 2 hours. It takes 20 to 30 hours of, labor. And sir is very, very, not just hardworking, he's putting the things in a smart way so that it goes in your mind completely. So this will be available for you all, whoever joins our digital class. Digital class link will be given to you. Where also will come and sponsor availability and you all choice. So you let us know. Meanwhile, you can just see the GT9. This is the WhatsApp code. Send to 9066990059. Another 2 minutes. You'll find the link. Put your name properly. Submit it. Within few seconds, you will get your certificate. Sometimes it goes to your spam, so don't check it only in inbox. If it is in spam, just download and keep with you. If you want a hard copy, you can keep it on a glossy paper. You can keep in your clinic, and keep in your file, wherever you want. So thank you so much, CEO sir. Thank you so much, Arunachalam sir, and thank you, Diwakar sir. Thank you, Kalim sir. Thank you all the participants. GT9. And those who have got certificate, just kindly put it in the chat also. Yes, you have got. So it gives other people also, like, yeah, it's working. Done?
Thank you.
Yes, sir. I think, sir, most of them they have done. Is there any issue regarding like link finding or anything like that? Is there anything? Don't keep sending, many a times. Just send once. Dr. Jahid Ahmad Khan, I think you are done. Did you get the link? Did you get the link?
Yes.
Okay, I think many of them they have got. Yeah, you were on video, so I asked, like, if not, just let me know. Thank you, sir, Misraji. Thank you so much. Nice to see you today also here. Yeah, thank you, Jayji. You have got it.
Thank you, sir. Thank you so much.
Thank you. Thank you, everybody. I think everyone has got GT9. WhatsApp this goes to 906679. Thank you so much, sir.
Thank you, sir. I'll leave. Yeah.
Namaskar.